a 9% cut of an already very meager fee schedule. And hopefully we can give you some options and spell those out in pretty good detail. We are hoping that each and every one of you has advocated to your legislators about this crisis we're in. We join hundreds of other associations fighting this decrease. And so anything that you can do will be helpful. Maybe we can get this delayed. So what are the course objectives? If I can get my picture smaller, you might be able to see this. There, let's see if we can do that. Okay, so at the end of the webinar, you should be able to, and I hope this plays out, be able to understand and list the enrollment requirements and options, explain the difference between being enrolled as a participating supplier and a non-participating supplier. And you notice I used the word enrolled. You have to be enrolled to participate or to not participate. I know that sounds like an oxymoron, but that's CMS. Evaluate the consequences of the fee schedule reductions related to your business viability and decide what enrollment path to take if indeed you want to change it. These are the complementary resources that you will find in links in the chat box.
Mary, Mary, you're not advancing. Your slides aren't advancing.
They're not advancing? Nope. You can't see them?
Nope.
Oh.
Sorry, guys.
Uh-oh. Why is that? Because they're advancing for me. Oh. I don't. Can you try? Can you take this?
I can certainly, 1 second, sorry.
Let's see here, maybe I can do it a different way. Can you see it now?
No.
Oh, you advanced before when I went to object. All right, let's try this. No?
Yeah, so go ahead, Mom. Stop sharing for a second and then share.
Okay, all right. And we will share screen.
Thank you for your patience, everyone. There's always these little glitches. Okay.
Over here. Okay. Working?
Okay, that's working. Okay, perfect. Okay.
Yay, sorry you guys.
Okay. Why don't you go back to the course objectives real fast?
Okay, to the course objectives. All right. So again, know the Medicare enrollment requirements, explain the difference between enrolled as a participating supplier and non-participating supplier. And again, that enrolled is critical. You have to be enrolled to not participate. So what can I say? Evaluate the consequences of what this reduction might do to your business viability, and also decide what enrollment path to take if you decide to change. So we are providing these resources if you need to change from participating provider to non-participating provider. We have instructions, we have demographic forms for you to have because you will need certain things in the letter that is required to send to your MAC. We've sent the supporting evidence that CMS has on its website, and then we have a template letter for you also. In addition, for those of you who do want, some of you have CEUs and some have CCUs, we have prepared what I routinely see as required in most of the states. So the PowerPoint presentation, you have to do a course evaluation, resume, biographical things, course objectives, and all of those types of things are available for you to submit for CCUs. You will, if you need a certificate, have to sign an attestation of attendance, and that's at the bottom of the evaluation, because that would have to come to us to verify. And I'm sorry, if you don't want to fill out the evaluation, you can, I don't know what you can do, but they'll probably require it. So we had a few terms and abbreviations, just so you know, because I've used these to keep the slides a little less dense. The Medicare Physician Fee Schedule, non-par is a non-participating provider supplier. Non-par limiting charge is 115% of the Medicare's allowable. Par is your participating provider, and we're going to get into what all this means. PACOS is the electronic platform Medicare uses to enroll. This will not be available to you if you are changing your participating status. You will have to submit a paper letter. A provider is not us in Part B. A provider is a facility, your rehab agencies, Part B SNFs, Part B home health agencies, and course, all provide services under Part A for facilities being paid by Part B. And we, the suppliers, are groups and therapists providing Part B Medicare services, just so we have that under our belt. Here is a disclaimer, and I want you to know, I've already had a couple of people tell me, boy, you're sticking your neck out there telling people to dump Medicare. And I said, well, we're not really telling people to dump Medicare. Services under Part. Hello? Okay. We are providing alternatives to you. And these are alternatives that possibly will help you offset the anticipated 9% fee schedule reduction, which would go into place January 1st in 2021. It's so important for you to understand if you change your provider status, your participating status, you can't reverse it for the entire year. You only have one chance once a year to do that. Typically that happens during the annual provider enrollment and change period, which is November 15th to December 31st of every year. This year, Medicare, thank you, Lord, has said, we're going to give you an extra month. So that gives you a little more time to contemplate what you want to do and also to see if things change favorably. So what are your options? One, you can eliminate all services to Medicare beneficiaries. I've heard this a lot when people are frustrated, but there's a lot to consider. You can cap services to Medicare beneficiaries. You can continue to move along just as you have if you are a participating provider, or you can continue to treat Medicare beneficiaries, but change your status from non-participating to non-participating from participating. Just to remind you, in order to treat a Medicare patient under federal law, you must, for Part B PTs, you must be individually enrolled as therapists and your group has to be enrolled. The benefits or the financial benefits that come with treating Medicare patients are assigned to the group if there is a group practice. Therapists in rehab agencies and the others are not allowed to choose anything except to participate. And those people enroll as a facility, not as individuals. This is my chance to jump on my soapbox. You must be enrolled. You can see that it is critical that you not use someone else's NPI to provide services until you have a confirmed application, approval of that application. Opting out is not the same as not participating. Opting out has to do with physicians and a few other practitioners. They have a separate contract, and Medicare has gone on record in writing saying this does not apply to chiropractors or to any physical, occupational, or speech and language therapists. So when you're evaluating the impact of the 9% cut, there are things that you need to know, and I'm preaching to the choir. I know you know how to run your businesses. This is just a checklist, especially if someone is helping you do the numbers. So you need to know the total direct and indirect expenses that cost to provide any of the service. What's your total cost, direct and indirect expenses, again, to provide an average visit? You'd have to know what your average visit is. So if it's 3 or 4 units per visit, then you can calculate it that way. What your average revenue is per patient over the last 2 to 3 years. I would not use 2020 by itself. This is not a good year to use to judge what might happen next year or what's happened in the previous years. And also the average revenue per Medicare patient over the past 2 to 3 years. What's your percentage of Medicare patients is critically important because, if you have 10% Medicare volume, then maybe that's not so consequential. If you have 50 and above, could be catastrophic if indeed the 9% reduction does come to full fruition. And when you look at this, the bottom line is the bottom line. Will this reduction put your revenue per Medicare patient below the cost to provide that service? If it does, you might have to consider alternatives. So what's our first option? Well, as I said, no Medicare. And these are the things that I think, from my perspective, when I was a practice owner, that I would be thinking about if I still had a practice. Could your practice survive if you eliminated Medicare services totally? Well, it's hard for me to admit this, and I know y'all are probably stabbing me in the back. I only had 4% Medicare patients. We lived in a very young urban, our practice was in a very young urban area. So the 9% probably wouldn't have impacted me. But again, you have to look at how your practice can survive. Would your non-Medicare referrals suffer? So our physicians, if you have a heavy referral base versus direct access, really be irritated that you stop seeing Medicare patients. But you have to decrease staff. What about public impression and public relations? Would that be negative? And I think the thing that probably gets to us, because we are very tied to our patients, is could we professionally and psychologically accept the decision, especially if people were voicing concerns or negativity on social media. And also, you have active patients. If you change, you do have the opportunity to continue to treat those until they are discharged. Is that what you would do, or would you just, cold turkey, close the curtain? What if you cap Medicare services? Most people are under the impression you cannot do that, but you truly can. You do not have to accept every Medicare patient that gives you a call, comes in with a referral, or whatever. You may accept a fixed amount of Medicare patients. Very different from contracts with some of the managed care plans where they say you will see all. But in this situation, the thing that you have to remember is you cannot cherry pick. That is, you cannot deny access that would be considered discriminatory under EEO or professionally. If you are just picking those that are fun or those that you have the best outcome with, that might be considered questionable. This doesn't mean you can't limit the types of diagnosis you accept, because all of us have our special niches. We have patients that we excel with because of maybe the special skills of our practitioners. And some go, I couldn't touch that because I couldn't do the patient justice. You do have, of course, those rights. So let's look at option 3. You can continue to stay a participating provider. Most likely, the large majority of you on this call are participating providers. And you did so when you completed the CMS 460 form when you applied as a group. If you started out as a sole practitioner and used the 855I for individual, and then you added staff, CMS creates I'm going to say a phantom group. You get a PTAN, that's a Medicare number, and those people are assigned to that. They do not have to select participating status. That comes with the group. If you're participating, you get paid directly by Medicare at its allowable fee. And of course, you cannot collect above the patient's co-share, which is their deductible and their 20% co-insurance at the Medicare allowable rate. you are accepting assignment on all of those cases. And that's illustrated in on your either your electronic claim or your paper. So you sign a participating agreement, that's 460. You accept the charges. Again, this is the allowed charges include Medicare and the patient. You accept the assignment, no balance billing. So you can't bill the patient anymore unless it's for a non-covered service. So for instance, if you have dry needling, yes, we have a code for dry needling, but Medicare does not pay for it. So it is a non-covered service. So you may bill that patient for the non-covered service and collect out of pocket. Again, you're not required to accept all Medicare patients. So what are the advantages of participating? Well, you actually are going to be paid 5% higher than non-par suppliers. But that's kind of a weird way of saying it. You're actually being paid the actual rate that Medicare has set in the fee schedule. The non-par suppliers are getting 5% less. So, and this comes directly from CMS language. So, you know, that's kind of, I guess, their way of making it look a little more perfect. Receive direct payment from Medicare. That's important because on your electronic claims, you get paid within 14 days in most situations if you have a claim. You are listed in directories for parts suppliers. I personally have never found that, but I've never really dug for it. So I guess that could be important if people are astute enough to know they want to go to a participating provider for their therapy. And you have a lot more access to claims processing and some of the interactive voice mechanisms that they have, which non-participating providers do. So option 4 is elect not to participate. When you elect not to participate, you still must accept Medicare patients and be enrolled, but you do not have to accept assignments in all cases. You can elect in some cases to do it yourself. The way this is accomplished is by not submitting the 460 at enrollment, but if you are a participating provider, you will have to send a termination notice to your MAC. And that's the information we have provided in the resources we listed on previous slides. It has to happen during Medicare's annual enrollment period for providers and suppliers. And as I said before, typically it's November 15th through the 31st. And now we have another month. Thank heavens for that. For those who are not participating, so not accepting the allowable fee schedule, routine assignment of benefits, these are the things that happen. You still have to bill Medicare. You can increase the patient's responsibility by 15%. That's called the limiting charge, which we refer to in our acronyms and terms, for a total of 115%. This is the clincher. Medicare will pay the patient. They pay them at the non-par allowable fee schedule. So again, it's 5% less than Medicare pays your participating provider. You may collect the entire amount for the visit from the patient at the time of service. And if I could blow that up and make it flash, I would do that because that is so critical. You don't collect, you fail. Non-participating practices have two options. They can accept assignment if they wish, or they don't accept assignment. So if they choose to on a selected basis, and again, you're going to have to make sure if you accept assignment when you're non-participating that you're not discriminating. You know, it's not everybody with this disease, or it's not everyone with this particular situation really probably should be tied to financial capabilities as much as possible. So if you accept assignment, changes how things happen as far as payment. Medicare will then pay you. The claim must be noted that you accept assignment. So that has to be physically checked, whether that's electronic or paper, and most everybody's electronic. But Medicare will pay you directly at 95% of the allowable amount, and you may not pass on that 15% limiting charge to the patient. So you are acting like a participating provider, but you get hit for an additional 5% reduction. So it doesn't make sense to be non-participating and to accept a large number of assigned patients. If you don't accept assignment, you may charge up to 115%, which is it should say at the non-par allowable. And you have the opportunity to, again, collect directly from the patient. So what are the advantages? Well, the potential to make more revenue than a participating provider. But the numbers really tell the story, and this came directly from the AMA. They had a little scenario, which you'll see the table that follow. The original table was from the AMA, and they went on record stating, and this may have changed because this table is a little dated, that if you do not collect at least 35% at full limiting charge, you will not be in a favorable financial situation. Because of, again, you take assignment, then you have that 5% reduction built in, which of course defeats the purpose of us trying to look at ways to offset a 9% decrease. So this is the table, and I know this is a challenge to read, and you'll really need to study it, but basically what I'm going to show you is prior to the cut, if we look at things at $100 a visit, just for the sake of ease, if you're participating, the total amount for that visit was $100, 80% paid by Medicare, so $80, 20% or $20 paid by the patient. Amen, bottom line, that's it. Okay. Non-par therapists that accept assignment are going to be dropped to that 95% non-par fee schedule, so it's $95. The amount that Medicare would pay is 80% of that $95, and the patient would pay 20% of the $95. So you can see that there is a reduction of payment when you have accept assignment and you are non-par. So if you choose to go non-par, you never accept assignment of benefits. So there's somewhere in between if you do some, but 115% at the non-par level, so that's $95 times 115 is your 109.25. All monies are paid to the Medicare, by Medicare to the beneficiary. So their $76 is going to go to the patient. So the Medicare pays $76 to the patient. The patient's co-insurance is $19 plus a limiting charge of $14.25. So yes, the patient is having to carry that extra financial burden when you change to non-participating provider. So the total amount you would be paid instead of $100 is $109.25. And you always have to step back and say, remember that slide that says, if I do this, can I live it? Is that $9.25 worth it? Well, today, maybe not. So let's go to the next slide. Whoops. Whoops, I went up. All right. So this, no, This is with the 9% reduction. So a part therapist, again, with the 9% reduction, $91. The amount Medicare would pay would be $72.80, and the patient would pay $18.20. So the patient does get a break also with the 9% reduction. And we are limited to $91 versus $100 that we would be paid in 2020. So if you are a non-participating therapist accepting assignment, let's look at the further reduction, 95%, excuse me, and you have that reduction, 86.45. Medicare then would pay 69.16, so they're 80%. The patient would pay 17.29, which is their 20%. And again, patient is put in a more favorable position. And the person and the entity that suffers, of course, is instead of getting $91, you would get $86.45 if you accept assignment as a non-participating provider. So if you never accept assignment, again, the rate is $86.45. You then add the 15%, which brings you to $99.42. Medicare is going to pay 69.16. The patient will pay $13.83, again a reduction, and then the limiting charge will be $16.43. So the total amount due from the patient is $99.42. The patient will be paid $69.16. So again, you have to prepare yourself for how you're explaining this to the patient and whether this offset is adequate to help you do business. $99.42 is a lot closer to $100 than 91. So you just have to do the numbers. You have to know your numbers. You have to know what those costs are to know if you are going to go in the hole treating Medicare patients if the 9% reduction comes to fruition. So again, if you accept assignment, I've kind of gone through that. Here are the dollar amounts. You can see that you put yourself further in the hole because it's an additional 5% reduction. And again, marking the claim to indicate accepting assignment is what will get you paid versus the patient. You forget to check that box. The patient will be paid and you will be a collection agency. Because once the patient receives your money, in most cases, they have already figured out how they're going to use that money. So please make certain if you accept assignment on a non-participating supplier claim that you do indicate that, so you will get paid your money. So this is a variance. So practice payment from Medicare, 2020, $80, 2021 with a reduction 72. The patient's co-share and it actually co-insurance, it was $20, now reduced to $18.20. So with a total payment of $91 for the same services would have been paid at $100. Patients' costs not reimbursed by Medicare. If we were non-participating in 2020, they would have a $33.25 bill, in addition to having to pay you for Medicare's portion out of pocket until they get reimbursed. And with the out of pocket, with the reduction, it's reduced to 30.26 because all of the other numbers go down. The practice payment from Medicare and the patient would be $109.25 for this year, and next year, $99.42. So I can't stress this enough. And sometimes I almost sit there and go, okay, but how can I say this so you don't make a decision that you can't live with? Changing your enrollment status to non-participating is a year-long, non-negotiable matter. If you send that paper in by January 31st, 2001, it's a done deal. And it's a done deal until the end of 2020. You have to look at changing your collection strategy and what it could cost the patient. This is when we get into, we have relationships with our patients. They don't just walk through the door and we dismiss them. The patient will be out of pocket for the cost of each visit for 14 days if you don't accept assignment. Medicare will pay them directly, and that's got to be something you tell them immediately. Now, if cash flow is an issue, possibly you might add another form of credit. A lot of people now are using care credit. I don't know if y'all use that, but many patients do use that. The other thing that kind of gets things a little tied in is many Medicare patients have supplemental insurance. And so how does that play into getting paid in the coordination of benefits? So you have to think about that. Could this reduce the number of visits? So a patient saying, well, maybe I could come once a week or maybe twice a week, but I can't come 3 times, I can't come as many times overall. That could change the number of visits. It could change providers. They could say, I can't do this, I have to go somewhere else. And it could possibly cause unfavorable patient relations. So accepting assignment is the next thing you need to be aware of. If you do it regularly, as I mentioned before, you could fail to offset the 9% reduction. And as a final note, most states do not limit the 15% limiting charge, but there are some states that have balanced billing laws that could limit the total amount. For instance, New York has a cap at 5% versus 15%. I haven't seen any others that do that, but you want to be certain you check your state and know whether their balanced billing laws, if they have any, apply to Medicare specifically. So I just want to advise you to be certain you check that, because if you were limited to 5%, then you have to look at, do those few dollars make a significant difference? So this is truly my soapbox. If you have at this time inadequate collections at the time of service, so you're chasing the dollar all the time, your AR is increasingly inflated, you will not survive as a non-participating provider. So you have to have hard-nosed people at the desk, kind and sweet, but collections oriented. If they're not able, if your front office is not able to explain why payment is due, what will happen in the process, and still get payment, then you will fail. You need to have a script for these individuals so it's consistent and firm at the same time. And lastly, if you don't have a united front, that means all staff, including clinicians, about going non-part, you will fail. So if front office is trying to collect and your clinicians are saying, I can't believe you did this, it's so unfair to you, you will never survive. So everybody's got to be on the same track. A few additional considerations. What if we are legislatively successful? What if the bills that are being put out there, what if they can tack on something to save the government legislation? What if those things happen? Well, my concern was we had to make a decision before the end of the year. Now we have another month. So you want to be tracking that very carefully. Another thing is, if indeed you sign the document, nothing happens in January, and the 9% does go into effect, you will, be able to benefit from changing non-part. But If you accept assignment on all of those, you're going to have a 5% reduction again on all your claims. So what if February 15th legislation passes? You're going to be saddled with that 5% reduction. So you have to have a certain amount of risk tolerance if you do this. You also need to really think, following through with your election as a non-participating provider. Don't routinely accept assignment. Your payment will be as we indicated in that second table. And this would be prior to the, on the first table, the one that shows payment prior to the 9% cut. So if that doesn't happen, you will be paid as it shows on that table. So how can we be compliant and collect cash? So many of you have heard me talk about mandatory claim submission, which I referenced earlier in this presentation. As long as you are enrolled in Medicare Part B and you comply with conditions of participation, and that means you do have to have policies, procedures, processes in place that guide you through compliance of their conditions of coverage. You decline to accept assignment, so you're enrolled but not participating. You collect both Medicare and the patient's co-insurance and limiting charge at the time of service. You file the patient's claim as non-participating, and then you take your money to the bank. This is all totally legal. So you can have your either $99 or your $109 in your hand versus waiting. And in a situation where those of you who do have a fairly large cash-based practice, you probably will handle that well. For those of you who are new to collecting cash, it might be a struggle. So do know that it is totally legal, but you need to have your P's and Q's in order. We know again, if a claim must be submitted to payers if the state law requires it. So you may have certain payers that they say, you got to submit a claim, amen, you cannot accept cash. If there's no law mandating that a claim submission must be made, a patient can exercise their right under HIPAA to restrict disclosure of their PHI, which would include all of their Medicare insurance information, payer insurance information, and then they can pay out of pocket. So it's important for you to realize that, and actually that should be, that is HIPAA. Okay, so that's the HIPAA right. That does not involve Medicare. And everyone thinks that the HIPAA right to limit disclosure applies to Medicare. Indirectly it does, but it's under a different law. So it's an exception to the mandatory claim submission. And it basically states, if a patient of their own will decides that they do not want Medicare to pay for their services that are being rendered by a provider, they don't have to allow the filing of a claim because they have to release the information if they did. So under that circumstance, you may collect out of pocket, but you must be enrolled in Medicare. If you are not an enrolled provider, this does not apply. Okay. These are penalties for non-compliance. So mandatory claim, you don't want to mess around with these. Can Medicare take action if you are not enrolled? Yes. The violations, civil monetary penalties, up to $2,000 for each violation. It could get you excluded from the federal program, and that's all federal programs. And also, if ever you wanted to get back in the program, it could result in an automatic 10% reduction for subsequent payments. Not a good thing when the fee schedule has its upfront potential limitations. So in summary, Therapists do not have to enroll in Medicare, but if you don't, you can't treat Medicare patients. You may limit the number of active Medicare patients you serve. You can enroll as a Part B provider and choose to accept assignment or decline accept assignment. And you may change that status during the provider enrollment period. This year again goes to January 31st, 2001. Non-participating providers can collect in full at the time of service at the non-par rate, including the limited charge. And Medicare providers may collect cash from the patient if he or she refuses to authorize the submission of a bill. So now we're ready for questions. If you have any, I know the tables are complex. Hopefully I've put enough things in parentheses to help you through the logic. I believe we've got a couple of people who are super skilled at this. I think Bob Wallach may be on the Zoom, and if he is, and I failed to explain it adequately, you can always put something in the chat and access Bob or other individuals who volunteer their expertise.
Okay, so I do have a decent amount of questions for you, Mary.
Okay.
So we're going to start with the ones that are in the chat box first.
Okay.
Let's just get in here. Okay. Okay. Okay, we're going to start with this one. If we're participating providers at the start of the new year, can we collect the patient's deductible at the time of visit, or are we required to wait until we get the Medicare EOB to bill them?
No, you may collect the deductible at the time of service and continue to collect it, throughout the visits that it is still not met. So the answer is yes, you may collect at the time of service.
Okay. So if you are a non-par and accept assignment, can you bill supplemental insurances, or can only bill the patient for that 20% over the non-par level?
Well, since you filed a Medicare claim, the coordination of benefits will play in. What I don't know is what the turnaround time is, but and then how you're depending upon the supplemental, whether they pay they're going to pay all the differences there, or whether they're going to pay a fixed amount. So that's something that you probably have to have the patient give you all the contact information for the supplemental to verify that, or that could be put on their shoulders because you may collect in full Medicare, okay, for the services delivered. And then if there was a payment made to you by a supplemental, then you would have to refund the patient. Or if the supplemental paid the patient, then all is good. I just don't have an exact answer to that, and I wish I did. I will pursue that though, see if I can get a reasonable.
And we've had a couple people ask about the secondary, so I'm not going to re-ask that same question. But if we didn't answer your question, and you had a different variation of it, go ahead and put it in the Q&A area and versus the chat box, so that I can kind of mark it as that it's been done.
And what we'll do is we will post our answers to questions that are unanswered.
Yeah, once we get the answer, yes.
It might be the early part of January before we do that, because researching what's going on and those types of things, it takes a little bit of time.
Okay, just as a reminder to everyone, the handouts were put in the chat box as a link, and then we also, for everything that we have here, if you decide that you do want to go non-par, I just put a link in the chat box. We have instructions and tools and sample letters on how you can do non-par. Okay, the recording is available and will be, any of you who are on Facebook, our Facebook live page, you can go to our Facebook anytime and see it, but I will also be posting a recording of this once it's done. Okay, let me get back in here. Okay. Okay. Does the 9% cut apply only to Part B Medicare, or does it apply to Advantage Medicare programs as well?
It does not automatically apply to Medicare Advantage, just as non-par status. So Medicare Advantage that have to offer the services that Medicare offers, but they don't have to offer them in the same way. So what I'm saying is they say, you got to offer PT. Well, they offer PT, but how they pay for PT, how they do their units, what they require for documentation, and obviously how they handle this cut is going to be based on them individually.
Okay,
We can't have an answer, but it is researching each one of your payers.
yeah. What specific services would be covered under the exception to the Medicare mandatory claims submission?
What particular services?
Yeah, I think it's any services.
Well, right. So if a patient just had a regular treatment and they said, yeah, I'm a Medicare beneficiary, but I don't want the federal government knowing anything about this condition.
Mhm.
And I'm just not going to give you that information. I want to pay out of pocket. That is fine. Now, if you post on your website,
Yeah. Yeah, you can't advertise that.
yeah, we will accept out of pocket and we will discount that. You're going to probably have somebody knocking at your door, and it's not going to be the people. It's going to be the people in the little black suits and the trench coats. You know, those people.
Right, right. Okay. Are there any changes with the recent charges to the reimbursement to critical care hospitals?
Oh, I didn't look up critical care hospitals. The reductions vary from like 1% to 17. So we're like in the middle. I don't know if critical care did, but what I understand, they really are trying to get to chronic care and primary care providers to get those increases through. And this all happens that the reason we have the reduction is to balance the budget. So I can't answer the question on critical care.
Okay, so I'm going to go into the
Note
other
that one, Alicia, as a question you need to follow up on, please.
1 second. Got it. Got it. Okay. Okay, so a lot of insurance companies, okay, we've actually just answered this one. Okay. Slide 13. Does this mean we could put a percentage cap or a number of patients on a cap on the Medicare clients we see? So that was the one where you was
right. When that was option 2, right? The cap. Yes, you can. So you could say I can only maintain 10 active Medicare patients over at any period of time. So you hit 10 and that's it. When a patient's discharged, you can pick up another one. I am very well aware of clinics that are doing that right now. And patients are in a waiting line. And in a lot of situations, patients don't want to be in that line, and they're saying, I don't care if you file Medicare or not, I'll pay out of pocket. I don't want to wait. Well, there's your, I don't have to file a claim scenario. But yes, you may put a cap. Again, I plead with you, please make certain it's not discriminatory. So it can't be every fireman who's over 65 on Medicare, okay? Or whatever. Someone actually asked me that.
okay. Do you have the 2021 limiting charge fee schedule yet?
It's not a fee schedule. The 15% is based on Medicare's allowable. So Medicare's allowable is out there now with the proposed reduction. There are multiple fee schedules. Again, I'll refer you to the APTA. Not only do they have a great Medicare fee schedule calculator, which includes your, well, right now sequestration is on hold, but multiple procedure payment reductions. And now they've added the non-participating factor to it. So you can query for that. I do believe Bob also has come up with an Excel calculator. And again, if you're interested in that, put it in the chat box and Bob can pick up your information, or we can post that somewhere where you can get a hold of it.
Okay, we've got quite a few that are talking about the same thing with the MPPR. So will it still be in place with the 9% cut?
Yeah.
Okay.
It will. Sequestration, we don't think so, but we'll see when they pass the fund the government legislation, hopefully by the end of this year. So when we look at all the reductions, and this is a comment that I made to someone the other day. I said, what profession is expected to run at break even? What industry? That's us. What industry has to go almost by a program to calculate what they're going to get paid? We start off with allowable fees, which change based on geographic areas. So that's one thing you have to know. Then you have to calculate sequestration. It's on pause right now. Then you have to calculate your multiple procedure payment reduction. And in 2022, we have to add in the reduction for PTAs before we can figure out what we're going to get paid. How do you do business like that? And I don't mean to be negative, because for the longest time, Medicare has been one of the stronger payers, but the administrative burden we're currently experiencing is overwhelming. And we have to speak to that, share that with your patients. The government tends to listen to the constituents, and Medicare in particular wants to satisfy their beneficiaries. If your beneficiaries aren't happy, nobody ain't happy, right? So it's something to think about, to have your patients and other consumers voice their concern about the administrative burdens, in addition to reductions that we are experiencing as healthcare professionals.
Okay. We have somebody who's enrolled in Medicare participating provider, but doesn't meet the MIPS low volume threshold. If they enroll as a non-participating provider, will that affect this Medicare Advantage contracts?
No, let's take MIPS out, okay? We cannot address MIPS here, but MIPS wouldn't have anything to do with participating and non-participating. If you must report MIPS, doesn't make any difference how you're getting paid as a provider, as a participator and not participator. But
okay.
As far as the question of, what's the second part of the question?
Oh, hold on.
It was.
Sorry, let me get back down. It was, will it affect the status of Advantage of a Medicare Advantage contract?
No, because you're still enrolled in Medicare, and that's the criteria. So
okay.
you are, remember, non-participating is just how whether you accept assignment or not, has nothing to do with you not being a Medicare supplier provider.
Okay. This is kind of off topic a tiny bit, but has there been any decision with Medicare if they will continue to cover telehealth?
They're expanding it in many, many ways, but at this point, we are still not listed under federal regulation as providers, permitted to do actual telehealth. I don't know if that will change. I don't believe it changed in the final rule. And correct me if I'm wrong. There's only 2,100 pages of that rule, and I do have to admit I haven't gotten through the whole thing. But in the summary, it doesn't sound like we have that automatically. It's going to have to be some congressional action.
Okay. Is refusing to authorize submission of a bill the same as signing a HIPAA form refusing PHI release to an insurance?
Say that again.
Is refusing to authorize submission of a bill the same as signing a HIPAA form, refusing PHI release to an insurance?
They're similar. They accomplish the same thing. Okay, so if you say non-disclosure and you have a non-disclosure form, you could certainly use that, and then it would be interpreted as, hey, I'm not giving you my information, so you cannot file the claim. So you could certainly use that. I probably would expand that form. I know that we have something that we use for our clients, a form that it's a letter that says this is my right and this is what I'm exercising.
And we do have some clients who are getting paid for telehealth in California, by the way. They're kind of commenting in the
So
comments.
they're getting paid now under the waivers. What Medicare is saying is when the pandemic is over, please Lord, happen soon, we are no longer under a waiver. So yes, all of us are getting paid.
Thank you for the
Yes.
clarification.
Mhm.
Okay, if a patient refuses to submit a bill to Medicare, what is stopping us from simply telling our patients to do this so we can ask for them to pay out of pocket? So this is the HIPAA question, very similar.
Well, they don't, you mean they refuse to allow the provider to submit. We cannot tell the patient to submit a claim. And if the patient does pay out of pocket, there can be no claim filed by anybody, patient's family member, the provider. It can't happen.
Okay. If non-par and collecting up front, you would need to know the billing codes used for that DOS to collect accurately. What is the problem if you're, what is the problem if you over collected accidentally based on codes used?
Well, if you have a billing error, okay, non-intentional billing error, you correct that. You refund the patient, you refund all parties that would have been basically had overpaid. So there's no problem. But you want to do things promptly because Medicare has a 60-day turnaround under the False Claims Act that says if you have our money, and that would relate to the patients as well because they were tied into that by a co-insurance, and you don't refund it, you could be in violation of civil monetary penalties and other federal laws.
Okay, if we decide to stay on as a participating provider and then halfway through the year, it's really hurting us, can we institute the cap on Medicare patients option to limit our Medicare patients at that point?
Yeah, there is no start and stop on that decision. You can cap your Medicare patients or you can eliminate taking Medicare beneficiaries at any point. The only thing you can't change midstream is your participating, non-participating status.
Okay. How will all this affect PTAs with our providers?
The 9% reduction puts us all in the same bucket. We're all going to be dealing with less money to do more. And whether that this particular thing is not going to impact a PTA any differently than it's going to, in my opinion, impact any other staff member. Okay, because you have a certain amount of money in which you can pay salaries and other overhead. Where we have the difference is if we do have that 9% and then it's compounded by the PTA reduction in 22, that's going to be a hard pill to swallow. However, and I don't personally believe that will change, okay, as far as the reduction, the PPA, OTA reduction, because we have been able to slide by for years when PAs and nurse practitioners and whomever else have had those reduced fees. So it would be very difficult to justify accepting us from that process.
If the provider responsible for correcting claims is the provider responsible for correcting claims so the patient can get reimbursed, i.e. wrong ID, missing modifier, etc.? Will the provider still get the ERA if non-par?
I'm not sure I understand the
I
question.
don't, ERA, do you mean explanation of benefits, EOB?
But that's the electronic remittance advice.
Okay,
Yeah, it's basically, yeah.
hold on. Yes, yeah, it was electronic. Jeannie, did you mean EOB or ERA?
Remittance advice is the RA. So,
ERA, yeah, okay, she had it right, okay.
right.
So, did you understand the question?
But I don't understand the question. Now we know what we're talking about, but I don't understand the question. I'm sorry.
It sounds like if you're non-par, will you still be getting an ERA so that you can make corrections if you need to?
Absolutely. It doesn't, yeah, you will, because you file a claim, you're gonna get your remittance advices. It's gonna have all the same information. And it will have further information because it'll tell you why you got paid less. So you'll see more remark codes and reason codes. The patient will get a Medicare summary as well as their EOB.
Okay. We're an outpatient facility, part of a hospital system. We have been told that Medicare patients are not able to pay out of pocket because it's against the conditions of participation. Did you mention that Medicare patients can pay out of pocket if we do not submit a claim?
So the conditions of participation under Part A would prohibit it. Remember when I said facilities cannot go non-par? So your rehab agencies, co-ops, Part B SNFs, and home health agencies. How the hospital PT department is organizationally aligned would make a difference, whether they are billing Part B, whether they are under the Joint Commission, whether they're under Part A conditions of participation. So hate to say I can't answer that. There are too many variables for me to answer that. But if they're billing Part A, then no, they cannot go non-participant.
Okay. Are there any questions out there that I overlooked? Because I think I've got most of them, or your question was answered in some way or shape during another question. So I just want to make sure that I'm not missing anything. So if you didn't get your question answered, would you put it back in the chat box or back in the Q&A for me? And while that's happening, wanted to kind of address, we do have all of the resources for going. Okay, here we go. What is the form that a patient would fill out if they do decide to refuse having us submit a claim?
There is no required form. I highly recommend you have one. As I said, we produced one in part of our forms in our compliance program that states, you know, of my own will, I have chosen not to release information for filing of a Medicare claim. I understand this puts blah, 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 you know, the financial liability on my shoulders. Amen. You can use the non-disclosure HIPAA form, but again, Medicare is different than the HIPAA disclosure. So HIPAA disclosure form really would be for your non-Medicares as it relates to payment. There are things that people file non-disclosures for that don't have to do with payment. It might be, don't tell my wife, or it might be, you know, limit this information to X, Y, and Z. So that there is no absolute form, but I will tell you, this is actual experience. You have patients who make decisions and then their children get involved and say, why did you pay cash? The provider has to bill Medicare. I'm going to pursue this. Well, you don't have any record. You have, you know, a steep hill to go up. So you want something written. And again, you can't provoke the situation. This really needs to be initiated by the patient in addition to that, that presents, well, I shouldn't say in addition. I've had people say, well, how do we let them know that this is a situation they can do? Well, you can do a public service announcement, but it's something that the patient really is supposed to initiate. It's just like when we got involved with virtual treatments and telehealth and all that. You're supposed to have the patient initiate, and they're supposed to be, they were originally supposed to be established patients. So it's the same kind of thing. How do they know this is available if you don't tell them? So, I mean, you could have signage or something that say you have patient rights. So if you have all your patient rights for HIPAA, you could put those. You could have little explanations next to them. And then you could add the additional patient right for your Medicare patients. So that would be probably the cleanest way to handle it without advertising it or soliciting that behavior.
Okay, so will Medicare Advantage plans apply this 9% cut? Hopefully
Okay,
not.
so not automatically, it doesn't automatically happen. Will they do it? What do you think? I think they will. I think other payers will. I was holding my breath yesterday when Texas released its workers' comp fee schedule, which has its own calculation, and typically it's based on Medicare, but they at least have a different formula. So I haven't gone in to see if they based it on the 9% reduction yet. So if indeed that happens, and many of you may have comp carriers that do that, they may factor in the Medicare reduction. So you want to look at that because this could definitely be a trickle down effect.
And just to make sure everybody who's still on knows this, we are recording this. We will post the recording in the link that I am putting in the chat box. It's where all the resources are. It won't be posted for probably a couple of days. We've got to let it process, and then I've got to convert it to a YouTube video, but it will be posted here. So this will be done. So another question is, how do we determine what Medicare clients should sign an ABN related to all of this?
I knew the ABN question was going to come up. Okay, so an ABN is to be used when there is no medical necessity any longer. Okay, so maybe you would use it if you wanted to give laser, or if a patient reached their goals, but the patient wanted to go further with their care. That's when you use an ABN. Again, this is telling the patient there is a financial liability for them and that you do not have to subsequently file a claim. It is not used for non-covered service. An ABN is, if it's non-covered, it's non-covered. You can collect cash. You just need to know that it's non-covered. So the ABN is for things that no longer are medically necessary or never were determined as medically necessary, but not in this particular Medicare arena.
Okay, so does a private pay option mean that the patient can be seen like direct access, so without a referral?
No. Okay, not automatically. That's a Practice Act issue. So if you have to go by the rules and regulations and the Practice Act stipulations for direct access. Medicare, again, you are still enrolled with Medicare. So you have to be enrolled. Medicare's requirement is that you have a signed plan of care. They don't require a referral or quote in parentheses prescription or order, but you still will have to have that signed certification of the plan of care. And that also, you don't have to worry so much about the NPI on the claim, which if you're filing a claim, you have to use an NPI for the certifying doctor. And with direct access, sometimes that's a problem. but direct access is a state law.
Okay. Last question for right now is, what is your guess about whether MCR will follow through with this cut, especially in light of the pandemic?
MCR, is that
I think
Medicare?
Medicare.
Okay, I just never heard that abbreviation. What is my gut? Well, up until the 1st of December, I thought they wouldn't do it. And so I don't have a good crystal ball. I do think that there is a tremendous move in the House to bring forth some type of solution, if not a temporary solution, and not permanent, a temporary solution. So the House bill that is proposed right now is supported by hundreds of doctors' signatures saying this is ridiculous. And so not doctors, excuse me, legislators' signatures. So I think we're going to have to rely on congressional action and not rely on Medicare granting us any type of free.
So for those of you that are still on, I want to go ahead and just share my screen and show you where you can find all the resources, just to make sure you're seeing everything correctly. So let me open
And one
that.
thing I do want to say while you're looking, Alicia, for those of you who are applying for CCUs or CEUs, this was billed as an hour-and-a-half program. By the time you finish your evaluation, which is short, you'll hit that time. So we will certify an hour-and-a-half because you are allowed breaks as well. So I think we're in keeping with the state laws as we know them. If indeed your state is more stringent, then please let us know. We can amend your certificate to reflect the proper CCUs units.
So what I'm showing you right here is our client resource portal. So the link that I gave you in the chat box takes you directly to this page right here. Let me open it up. Sorry, we got a little drag. This is if you decide that you want to go non-par. Here are the instructions, the stuff you should, basically collect, your max by state, the temporary letter, or sorry, the template. If you want CCUs, you can click here and it will take you to the page where we give you all of the resources that typically are required. We would appreciate any of you that are on filling out an evaluation form for us and emailing me at mahoney@bcms.comp. That email address is right here. That is typically required to get CCUs or CEUs. But if you're not even going to try to get CCUs for this, we'd still appreciate the evaluation. All right. Mary, do you have anything else? I think we had one more question. I felt like something, I got an alert somewhere. I think I got everybody. Okay. And there was no more questions. Let me just make sure I'm not missing anything. All right. Okay, it looks like I may have got a couple chats in here. Let's see what those.
One more. Charles Stevens said he has one more.
Yep, one more. What's up, Charles? Okay, so Joseph, I just put the link. I will put the link here again in the chat box, so you can go there. It will allow you to go to the area that I just showed you. Charles, let's see. I think you put it in the actual question. Here we go. Oh, this is from Linda McClanahan. Are the resources limited to people who are BCMS members? Actually, they are not. We are hoping that this goodwill faith, you guys will be interested in our services and ultimately become a client of ours. So hopefully you will use the resources and see the kind of work that we do. Okay. As a practice that sees 99% Medicare patients, what advice do you have?
Oh, hold on tight. Again, knowing your costs, knowing your Medicare percent, your mix, those things are going to be very important to know whether you could survive it. I probably would strongly consider non-participating. But again, then you have to look at the what ifs. Are you going to lose patients? Are you going to irritate, your potential or your current refers, that type of thing? What will public relations be? But you can't run a business in the red. That's the bottom line. You might have to make very tough decisions. And I totally regret that, but that's a fact. And I think if I were you, I would develop a letter that you could give the patients that they could then send Congress, they could send CMS, all of the information. The APTA has some really good letters. They have letters from patients, that type of thing that you could use for templates. But I would start a patient campaign saying, this is what's happening to me. And my provider is having to pass on the cost to me. And if they listen to to their beneficiaries, then maybe we'll see a change.
All right. Big thank you. And by the way, Mary, it's a relatively new client who was asking that question. So sorry. All right, everybody. I'm keeping up with these. Okay. All right. I think that we're good. If there are no more questions, we're going to wind up 6 minutes early. We certainly appreciate all of you taking time out of your day. Like I said before, the link is in the chat box, so you can go to those resources. The evaluation is on the CCU page, so if you want to provide us with an evaluation, and email me at mahoney@bcmscomp.com. That would be great. We're always looking for feedback. And then lastly, we appreciate your time and hope that everything will get better as soon as possible.
And in the meantime, stay healthy, be safe, and in spite of everything that's going on, please take time to enjoy family and friends in limited capacity, of course, social distancing, throwing kisses and all. Be what? Don't breathe on them.
Absolutely. Well, we appreciate your time, everyone.
Okay. You have a great one. Bye.